Good morning. Well, it's morning here in the United States, and good afternoon in Cameroon, and evening in other parts of the world. Welcome to the Health for the World Medicine International Grand Round. Today we have Dr. Abraham Cooper, who we're very excited to have as our guest faculty. He is Assistant Program Director on Pulmonary Critical Care Medicine at The Ohio State University Wexner Medical Center, and has an exceptional background in education with various awards, the recent most Arnold P. Gold Foundation Humanism and Excellence in Teaching Award as of last year. He will be talking about a very important and pertinent topic in today's climate, mechanical ventilation. I will let him take it away from here. Again, Abraham, thanks for your time and being part of this program and initiative.
Thank you very much. Let me share my screen here. Okay. Can you see that okay?
Yes.
Title slide, okay. And can you hear me all right?
Perfect, yes.
Okay, great. Thank you very much for that kind introduction. My name's Avi Cooper. As you said, I'm an assistant professor at Ohio State. I'm the assistant program director of the Pulmonary and Critical Care Fellowship. And I spend a lot of my time in the intensive care unit taking care of critically ill patients. And it's really an honor to be invited to speak to you all and to join this community of learners and educators from around the world. And I think the mission of the Health for the World organization is really amazing. And so it's a true honor and pleasure for me to be here with you today. And as you mentioned, this is really a very important and I think pertinent topic. The management of ARDS and refractory hypoxemia, and maybe never before has mechanical ventilation been, in the lay press and talked about, I think, at a cultural and societal level across the world. I think it's really a unique time in history in that there's kind of a light being shown on critically ill patients because of COVID-19. This talk is not COVID specific, but all of the principles we're going to talk about are going to be relevant to the care of COVID patients. So I hope that it is useful in that regard. If you want to reach me after this, I'm active on Twitter at Avram Cooper MD. You can reach out to me anytime. And I wanted to start with a case. A 50-year-old male with a history of IV drug use presents with MRSA bacteremia, encephalopathy, and hypoxia. And his oxygen saturation is 83% on room air. He's then intubated, and his initial P to F ratio is 120. So that's the PaO2 to FiO2 ratio of 120. So after intubation, what should you confirm? Now, the goal of this talk partly is to give you all strategies or practical strategies to think about how to care for the critically ill patient. Things like setting the ventilator and some evidence-based approaches to that. And we'll also talk about some more advanced strategies for refractory hypoxemia. But just to be very basic, the first thing you should confirm is to confirm the endotracheal tube position when your patient is intubated. And we use capnography to detect CO2 in the exhaled breath to confirm that it's in the trachea itself and not in the esophagus. We listen to breath sounds on both sides of the lung. And traditionally, the tip of the endotracheal tube should be 2 to 5 centimeters from the carina. And this is an example here outlining the tube in red of an appropriately positioned endotracheal tube. And if it's too high, the patient's at risk for self-extubation or accidental extubation. And if it's too low, then you could end up with a right mainstem intubation, both of which would obviously be problematic. So back to the case. So what diagnosis does he have? So this patient has moderately severe ARDS. And so the Berlin definition that you may have heard of, that back in 2012, the ARDS or ARDSnet network, which is now called the PEDAL network, largely for research purposes, but also clinically relevant, came up with a unified kind of global definition of the acute respiratory distress syndrome, or ARDS. And the criteria for this involved the timing of the illness, some certain chest imaging findings, the origin of those chest imaging findings, and hypoxia. So the timing, it needs to be acute, and so it has to be within 1 week of an clinical insult or onset of symptoms. Chest imaging, there traditionally should be bilateral opacities, although sometimes patients can have, more, it doesn't necessarily have to be symmetric. You can have, more infiltration on one side of the lung than the other. And that the edema or opacities can't be fully explained by volume overload. And so sometimes patients will be volume overloaded, but still also be in ARDS. So it can't be fully explained by that. And then the degree of hypoxia. And so this is stratified by mild, moderate, and severe, and that's determined by the P to F ratio. So the lower the P to F ratio, the more severe is the ARDS. And the one ratio that I really want to call your attention to is the P to F ratio. If it's less than 100, that is someone who is very sick and they have severe ARDS. And that will be someone later in the talk that will probably receive some of the refractory hypoxemia strategies that we'll discuss. So next I want to talk about just some basic mechanics of mechanical ventilation and things that you can control on the ventilator. And for this next set of slides, I do want to give credit to three of my colleagues at Ohio State, Drs. Quaney, Fussner, and Horowitz, who created these slides. And so thank you to them. So the most common mode of mechanical ventilation that your patients will be on will be, and it's somewhat antiquated terms now, but the terms we use are assist control, volume control. And essentially what that means is you as the practitioner have control from the ventilator of the tidal volume that the patient is going to receive, and you're also controlling a minimum respiratory rate. And we'll also talk about you set things like PEEP and FiO2. But the hallmarks of this are controlling tidal volume and respiratory rate. And so the respiratory rate is the minimum number of breaths per minute that the ventilator will deliver. So if you dial in 18 breaths per minute, the ventilator will, at a minimum, the patient will receive 18 breaths per minute, but they are free to take breaths over that. And so their actual respiratory rate may be higher than the one that you set. Next is the tidal volume. So with each of those breaths, the tidal volume, which is measured in milliliters, that is the size of the breath that the ventilator will deliver. Next is PEEP, and this is positive end expiratory pressure. This is pressure that remains in the lungs after each breath is delivered, so at the end of exhalation. And then lastly is FiO2, and this is the fraction of inspired oxygen that is being delivered by the ventilator, and it can be anywhere from room air, or 21%, up to 100%. And so if we think about what these all convey, there really are two levers that we're pulling on the ventilator that we're controlling. And one is ventilation and the other is oxygenation. So ventilation is controlled by respiratory rate and tidal volume. And if you multiply those, you get the minute ventilation, how much ventilation is delivered over the course of a minute. And then oxygenation is controlled by PEEP and FiO2. And so you want to just keep in mind that when you're changing respiratory rate, you're probably not going to change oxygenation. When you change PEEP, you're probably not going to change ventilation. And so you want to just be clear about which of these two factors you're controlling when you're making changes on the ventilator. So now when you're thinking about setting the ventilator, let's break down how you're going to determine each of those different components. So let's first start with tidal volume. And way back in the year 2000, the ARDSnet, or the ARDS network, did a study looking at the impact of giving lower tidal volumes versus higher tidal volumes on mortality in ARDS. And what they found was a pretty pronounced difference between the groups, where the group receiving lower tidal volumes had a lower mortality. And traditionally, the number that you may have seen is 6 cc's per kilogram, or 6 cc's or mLs of ideal body weight per kilo, or 6 mLs of tidal volume per kilogram of ideal body weight. Although 4 to 8 cc's per kilogram is still technically acceptable and considered low tidal volume ventilation, but lower is better generally, and 6 is often our starting point. There are many potential reasons for why this might be, but the one kind of core teaching point or take-home point that I want you to leave this talk with is that the lung mechanics on the ventilator often drive the patient's mortality. So the more that we can do to improve their mechanics on the ventilator, the better. And one way to do that is to avoid over-distending the lung. Over-distending the lung stretches it and further propagates the injury that the patient will receive. If you think about the way that we breathe with negative pressure, right? So we draw breaths in by negative pressure. It's not physiologic to receive positive pressure, basically having air pushed into the lungs. That's not a physiologic way to breathe. And you can risk over-distending the lung. And so the goal is to minimize that over-distension and further injury. And so one of the ways to accomplish that is to use lower tidal volumes on the breath. Next is setting PEEP. And you may have seen these tables before. These are the PEEP to FiO2 tables, or some people call them ladders, that were developed, they're used by the ARDS network in many of their earlier trials in the 2000s. And what these essentially do is pair FiO2 and PEEP. And so if someone is hypoxic and you tune up the FiO2, you may make their hypoxia better, but you're not necessarily accomplishing all the goals that you might have, which would be to improve the mechanics of their breathing on the ventilator. And one of the goals that we have is to recruit lung that may be collapsed or atelectatic and filled with fluid, to open those up with PEEP. And so the key is to have adequate PEEP to keep those areas open. You don't want to use too much PEEP, but you also don't want to use too little. And so what these tables do is walk the PEEP level up in tandem with the FiO2. If you're turning up the FiO2, you should also turn up the PEEP. And again, these are specifically for patients with ARDS who are hypoxemic. And there are lower and higher tables, and essentially the higher tables use higher levels of PEEP for any given FiO2. I'd say most of us in critical care practice are using the lower PEEP tables here, but I wanted to present both because they both are out there in the literature. But the lower one is probably the one we're more commonly using. And as you turn up the PEEP, you're often able to turn down the FiO2, which we'll talk about why is a good thing to do and helpful for the patient. You do want to watch out, though, for hemodynamic effects at higher levels of PEEP because of effects on ventricular preload, that it can decrease that. And so that's something to be mindful at higher levels of PEEP. But in general, don't be afraid to up-titrate the PEEP in patients who are hypoxemic with ARDS. If you're turning up the FiO2, you should probably also turn up the PEEP. So next is, if you're going to be monitoring the ventilator, what are some things that you're going to think about? And one of the main one is probably going to be plateau pressure. And this is an example of a pressure and time curve or scalar that the ventilator will show you. And you can see that the breath, the inspiratory breath, the positive pressure inspiration occurs. And it takes you up to PIP, or the peak inspiratory pressure. Then if you do an inspiratory hold, meaning you don't let the breath exhale, you don't inhale more, but you also don't exhale. If you just hold that pressure, then the pressure that it the pressure that the lung settles out at is called the plateau pressure. And this, the plateau pressure reflects the intrinsic stiffness of the lung. Higher plateau pressures mean more stiff lungs, or harder to inflate. And then as you let the breath out, the pressure settles down to PEEP, which is the pressure at the end of exhalation. Because of some work done by the ARDS network in the 2000s, we've determined that the goal plateau pressure is less than 30. Less than 30 is associated with decreased mortality. And we'll use PEEP or tidal volume to try to get that plateau pressure down to less than 30. Another metric that you might have come across or hear about in the future is something called drive pressure. And this is something that maybe in the last 10 years or so that intensivists are starting to monitor more and be more mindful of. And the drive pressure is the plateau pressure minus the PEEP. And what it reflects is it's kind of a more accurate measure than just the plateau pressure of what that distending pressure or stiffness of the lungs is. And a lower drive pressure is associated with a less stiff lung. And so the goal is to have a lower drive pressure. And you can still use PEEP and tidal volume adjustments to try to get the plateau pressure or the drive pressure down. And the goal is less than 15. So we talked about the plateau pressure goal less than 30, drive pressure less than 15. And the reason for the drive pressure goal of less than 15 is based on this trial from the New England Journal that looked at the association between drive pressure and survival in ARDS. And what they found was, if you look at the center of the graph, and they looked at mortality on the y-axis and drive pressure on the x-axis, the mortality seems to start to rise when the drive pressure is greater than 15. And so that is a source of our practice for using drive pressure of 15. Now, one last piece to setting the ventilator is to avoid hyperoxia. And we talked about that when you turn up the PEEP and FiO2 together, if your oxygenation improves, you should try to turn down the FiO2. That is because hyperoxia is bad. So more oxygen in the lungs than is necessary is associated with free radical, oxygen-free radical formation and further damage to already inflamed lung. And this trial from JAMA in 2016 looked at an oxygen titration strategy that was conservative, meaning they more aggressively and deliberately titrated down that the FiO2 versus a conventional approach. They saw an increase in mortality with the traditional conventional titration, and with a more conservative approach, trying to get those FiO2 numbers lower was associated with improved survival. So in general, avoid hyperoxia and turn down the FiO2 as much as you can. So we're often titrating to oxygen saturations of 90 to 92. So if you see that the ventilator, that the pressure, the patient is saturating at 100%, you don't necessarily want that in ARDS. You want them to be in those lower to lower 90s, because that means you're not giving them too much oxygen. Okay, back to our case. So we've set the ventilator and we've used some of the settings that we've talked about today. So we've set a respiratory rate of 22. We set the tidal volume at 60 cc's per kilogram of ideal body weight. And the PEEP is set at 14 and the FiO2 is at 90%. And with all of that, the patient is desynchronous with the ventilator. We do get a plateau pressure reading of 28 and a dry pressure reading of 14. So we're meeting our goals on those two metrics. But the saturation is still 86%. So the patient is not doing well. So what would your next intervention be? So this patient has refractory hypoxemia or severe hypoxemia that we need to do something about. And so these are the 4 strategies that we're going to talk about today: sedation and paralysis, proning, inhaled pulmonary vasodilators, and then venovenous ECMO. So the first goal in ARDS in general, and especially in patients who are severely hypoxemic like this patient, is to avoid patient ventilator desynchrony. I'll show you some examples of what that means, but essentially the patient and the ventilator not breathing in tandem with each other, not being in sync. And this is generally achieved initially with sedation and sometimes deep sedation to drive down the patient's own respiratory rate so it will match the ventilator's respiratory rate that we have set. Desynchrony can worsen oxygenation and ventilation. It propagates lung injury. It's uncomfortable for the patient. Although one caveat is that there's no evidence of impact on mortality, though, that has been demonstrated. Here are some examples of desynchrony, and these are pressure, flow, and volume tracings that you might see on a ventilator. And it's probably best seen in the pressure tracing, where these different lumps and bumps in the pressure tracing that shouldn't be there those are the results of desynchrony. And what those are is the patient trying to breathe, take a breath in the middle of the ventilator's initiated breath, or trying to breathe during the exhalatory phase, and the ventilator is not allowing the patient to get a breath, or the patient tries to exhale during inhalation while the ventilator is delivering a breath. All of these are examples of desynchrony that you don't want in someone with ARDS, because these are going to further injure the lung. Now, and we will use deep sedation to achieve that, but you also don't want to over-sedate the patient. The reason for this is that the more heavily sedated a patient is, the longer they're going to spend on the ventilator, and the longer they're going to spend in the ICU. And so this is an older trial from 2009, but they randomized light versus deep sedation approaches, and they looked at the kind of cognitive and psychiatric outcomes, and as well as other clinical outcomes after critical illness. And as I mentioned, the patients who received higher levels of sedation, the Ramsey scale is one that we don't use much anymore, but higher levels on the Ramsey scale or higher levels of sedation, those patients that were more sedated had longer stays on the ventilator and longer stays in the ICU in general. So you only want to use the minimal necessary sedation that you can achieve the ventilator synchrony, patient ventilator synchrony that you want, but you don't want to sedate them more than you need to. Now, some patients will you will not be able to achieve synchrony despite deep sedation. So they will receive high levels of opiates or other sedatives to try to drive down their respiratory rate, but it may be unsuccessful, and they may continue to have desynchrony. That is a situation where you might consider using paralysis. And so neuromuscular blockade to essentially make the patient completely passive on the ventilator and relaxed, and allow us to breathe, to control the dynamics of their breathing with the ventilator. And so this had been studied, and previous smaller studies had suggested that maybe there was actually a mortality benefit for early neuromuscular blockade during ARDS. But to try to definitively answer this question, the PEDAL network, which again is what the ARDS network evolved into, looked at early neuromuscular blockade. And they randomized patients to receiving early neuromuscular blockade within, I think, the first 48 hours or so of critical illness, or kind of usual care. And they essentially saw no difference in outcomes, especially regarding mortality. And so there didn't seem to be a benefit to giving paralysis to all ARDS patients. But that being said, it's still helpful, and we still certainly use it for severe hypoxemia when patients are desynchronous, despite deep sedation. So we always try deep sedation first, but if they continue to be desynchronous and hypoxemic, that's when we'll paralyze them, but we don't paralyze everybody. Next is prone positioning. And so what this involves, and this has gotten a lot of discussion in the lay press as well, because of its use during COVID, is turning the patient on their belly and breathing for them, and having them stay there for typically up to 16 hours per day. And breathing for them and having them ventilate that way, and then turning them on their back, but then continuing that process. And there's a long history of studying the potential benefits of prone positioning in the critical care literature. The study that guides our current practice today is the PROCEVA trial, which was published in 2013 from France. And they looked at the use of early prone positioning in severe ARDS. And so they randomized patients to either prone positioning or not using prone positioning. And you can see at the table on the left, they had fairly typical settings for what we have been talking about today. Their tidal volumes were low, about 6 cc's or 6 mLs per kilogram of their ideal body weight. Their average PEEP was about 10. Their FiO2 average was about 80. And their P to F was on average 100. So this was patients with severe ARDS. And you can see on the left, when they looked at survival, the patients who received prone ventilation had a markedly improved survival compared to those who did not receive prone ventilation. And this guides our practice of using prone ventilation or prone positioning in this group. And so the theories as to why this works, there are a couple of different reasons for this. If you've ever turned someone prone with severe ARDS, it's almost like magic. You turn them on they're on their back, they're severely hypoxic, you turn them onto their stomach, onto their belly, and within minutes, their oxygenation dramatically improves. And so one reason for that is probably better VQ matching. And so if you look on the top, the ARDS tends to involve, because it's the inflammatory markers that drive ARDS are brought there by blood, it tends to involve the more dependent regions of the lung. And but the blood flow, there's more blood flow going to those dependent regions as well, again, for the same reasons. And when you turn someone on their belly, you flip that. And so the more blood flow is going to the healthier, more kind of upper parts of the lung, or less dependent parts of the lung, and so you get better VQ matching. But the main reason why prone positioning is helpful and seems to improve mortality in ARDS is you get improved lung mechanics. And as you can see here on the bottom position, the bottom of the figure, when you turn someone on their belly, you move their heart and chest wall from off of those bottom parts of the lung, and you allow them to expand. And so this is recruitment. You open up those areas of lung, you improve their lung mechanics, and you reduce further injury from the positive pressure on the ventilator, and hopefully help kind of expedite healing of the lung from ARDS. So these are probably the two main reasons why prone positioning is helpful. Now, we also sometimes use inhaled pulmonary vasodilators to help with hypoxemia. And these target, we use inhaled epoprostenol and inhaled nitric oxide. And these target two pathways that both control the pulmonary artery vessel tone, the prostacyclin pathway, which epoprostenol targets, or the nitric oxide pathway, which inhaled nitric oxide obviously targets. And signaling through either of those leads to vasodilation, relaxation of the pulmonary vasculature. And so why this might be helpful is the key is to use the inhaled versions of these. So this wouldn't be helpful if you gave these systemically, but using things, but giving these medications, giving a nitric oxide and prostacyclin inhaled, you get preferential the drug delivery to the parts of the lung that are better ventilated and recruited, and preferentially vasodilate those areas of the vasculature in those areas of the lung, drawing more blood flow there, which will improve EQ matching and improve hypoxemia. But there's no change in lung mechanics. So as you might imagine, just improving hypoxemia without changing lung mechanics, you might not be associated with an improvement in mortality in ARDS. And that's exactly what has been shown in the literature. And so this was a meta-analysis from the BMJ that looked at outcomes with nitric oxide, inhaled nitric oxide use. And as you can see on the bottom left, there was an improvement in mortality, or in oxygenation, I should say, which is not surprising based on the mechanisms that we've talked about. But as you can see on the right, there was no effect on mortality in ARDS from nitric oxide. Similarly, with inhaled epoprostenol, this study looked at oxygenation and blood pressure, so-called the tolerability of the medication. And this study in chest found that the hypoxemia did improve. The P-to-F ratios went up with the medication, which is a good thing. And the blood pressures of the patients didn't go down, so the drugs were well tolerated. But this systematic review from the Cochrane group showed that there was no evidence of mortality benefit, just like with nitric oxide, for inhaled prostacyclins or epoprostenol. And so as a result, this is an option for rescue therapy for refractory hypoxemia, but it should not be first line. These interventions should not be first line for hypoxemic patients. Things like adequate PEEP, low tidal volume ventilation, and deep sedation, paralysis if needed, and prone positioning, like we talked about, those should always be done first before reaching for an inhaled pulmonary vasodilator, but sometimes we just have to use it as a rescue therapy, and we do. Lastly is Venovenous ECMO, and not all centers or hospitals have this capacity. This is a more advanced therapy, but even if your hospital doesn't have this, it's still worth knowing about. And so what Venovenous ECMO is it's essentially lung replacement. And so cardiac surgeons will place large catheters in either the veins in the groin or in the neck. And blood is deoxygenated blood is pumped out of the patient and then passed through an oxygenator, or a blender, which allows for exchange of oxygen and carbon dioxide, so clearance of carbon dioxide and oxygenation of the blood, and then it's returned back to the patient, and it's in an oxygenated state, and it can then be delivered to the rest of the body. So you may have seen veno-arterial ECMO, which is or VA ECMO, which is heart and lung replacement. This is just a lung replacement, and it's used for patients with refractory hypoxemia. It's also used for patients with acidosis or acidemia that you're not able to control or adequately treat with a ventilator. And so those are the two most common things that are reasons to refer someone for VV ECMO and ARDS. And this intervention itself, we only usually do it after we've tried all the other things that we have in our arsenal, because this is much more invasive. And so we'll do the other things that we've talked about: prone positioning, paralysis, inhaled pulmonary vasodilators, and if we still cannot adequately treat the patient and get their oxygen levels up or control their acidemia, then we'll refer for VV ECMO. Now, there are contraindications. Usually when patients have already been on the ventilator for 7 days or more, they're not candidates for ECMO, or if there's another life-limiting condition that they won't benefit overall from ECMO, such as irreversible brain injury or untreatable metastatic cancer. And to prevent clotting or thrombosis in the circuit, all these patients have to be on anticoagulation. And so if the patients have a contraindication to anticoagulation, they can't go on ECMO. And it's worth knowing about this trial, the Aiolia trial, which is the most up-to-date literature on the use of ECMO in severe ARDS. And this trial randomized patients to receiving early ECMO for severe ARDS or usual care. And it actually was stopped early by the Data Safety Monitoring Board because they thought they were seeing an ECMO benefit. But then when the final analysis came out and was done, there was a trend toward a mortality benefit, as you can see on the curve on the left, where the ECMO group seems to have a higher survival than the control group, but it wasn't statistically significant. That was probably because of underpowering, because the trial was stopped early. And so a lot of people in the critical care community think that if it had continued, it probably would have shown a mortality benefit, but we can't know for sure. It did confirm the role of VV ECMO, though, as an early rescue therapy in appropriate patients. So it's not something that should be used in all patients with severe ARDS, but for appropriate patients who are refractory despite our traditional strategies and typical strategies, early referral for ECMO is better than later referral. So just to wrap up, I wanted to conclude with some general best practices in ARDS. One is a conservative volume approach. You may have heard the phrase dry lungs or happy lungs, and I think that's true. And so limiting IV fluids and using diuresis early as appropriate are important strategies for helping patients improve on the ventilator and come off mechanical ventilation. And I wanted to refer you to the Society for Critical Care Medicine's ABCDEF Bundle, which most ICUs now are using some version of this. And so this looks at addressing pain, making sure that patients are being tested for their ability to come off the ventilator, using analgesia and sedation, that trying to minimize the use of them like we talked about, and avoiding things like benzodiazepines where you can, which are more deliriogenic, doing other things to prevent delirium, and having early mobility and exercise, so walking patients as able on the ventilator to keep their strength up, and also involving family, engaging family. This bundle is a really, really important part of helping patients survive critical illness and then also thrive as they recover 60, 90 days, a year down the road to help improve their long-term outcomes after they survive critical illness. So in summary, always use low tidal volume ventilation. It's very important. Adequate PEEP is important in severe hypoxemia from ARDS to recruit lung. You want to sedate to achieve synchrony with a ventilator and paralyze if still desynchronous despite sedation. Have a low threshold to prone patients with ARDS. And inhaled pulmonary vasodilators and VV ECMO should be reserved for refractory hypoxemia, but those are certainly options as well. So thank you very much. I'm happy to take any questions.
Wonderful. Thank you, Avi. Very pertinent topic and great slides and essential content. Thank you very much. Over to our classroom there in Cameroon, Mabenga Baptist. Hi, do you have a question? Feel free to, I will unmute. Let's see. Oh, I'm trying to unmute you. Why don't you try to unmute yourself as well? At the bottom left, you will see, yes. Go ahead.
Okay. I have a question. Thank you for your presentation. My question goes thus: when you were presenting the case study, the PEEP that you showed was 14. And here we usually start at a PEEP of 5. And if you start at a PEEP of 5 and use that plateau pressure at less than 30, or let's say 30 maximum, it gives a drive pressure of about 25. So, but your talk says that the optimal drive pressure should be about 14. So, are we doing it? Am I doing it wrongly? Because usually when I start ventilator settings, that's what I go towards. And then the respiratory rate, I realized that the respiratory rate of the patient on your case study was 22. Usually we start with respiratory rates between around about 16 or 14. So was that not too high?
Thank you for your question. So regarding PEEP, my own practice, I usually start around 10. And the reason for that is if you start lower than that, so when you're intubating someone, they're often apneic for a period of time, and what can happen is the lungs can actually de-recruit during that time, and when they're not receiving any kind of breath when you're intubating them. And so if you start the PEEP too low, they might actually be severely hypoxemic, and it can take some time to kind of open that lung back up. And the longer that it's down, the longer it takes to open back up. So I usually start around 10. You don't want to drive the PEEP up too high either when you first intubate someone, because as we talked about, PEEP can decrease preload and could have hemodynamic effects. And often when patients have been sedated and paralyzed for and going on positive pressure when they're intubated, they can have hypotension, hemodynamic collapse. So you don't want to give them too much PEEP, but you also don't want to give them too little and de-recruit them. And so I usually start around 10. And you can go kind of up or down depending on how the next hour or so goes, but I'd suggest starting higher than 5. Regarding the respiratory rate, what you want to make sure that, I didn't really get into this because it's, I didn't get into this into the talk, but you want to try to match the patient's minute ventilation from where they were pre-intubation. So if the patient has a pH of say 7.1 and they're breathing 30 times a minute, if you put them on the ventilator and you breathe them at 16 times a minute, they're now getting probably about half the minute ventilation of what they were doing on their own. If their pH is 7.1, it's going to be 6.9, and they might have a cardiac arrest. And so what I try to do is to try to approximate, so if the patient was breathing faster to keep up with acidosis before they were intubated, try to do the same thing a little bit afterward to match that and try to protect their pH from dropping more. Respiratory rate of 22 in someone who wasn't particularly acidotic, 22, 24, somewhere in there is probably where we'll start. I try to start around there just to make sure that we don't end up with making acidosis worse.
Thank you. Any other questions or case scenarios that are challenging for you over there in Cameroon you want to discuss? While you are discussing, I do have a question from our wider audience as well. How high a PEEP is too high in the setting of severe ARDS? Or can we keep on going high if hemodynamic parameters permit? Patients with severe ARDS often have ongoing vasopressors as well, especially in the setting where we do not have ECMO.
It's a great question. And so we're often, there's two ends of the spectrum that you want to be mindful of. So on the one end of PEEP use is too low. And we talked about that can lead to under-recruitment, so the lung can collapse and it's hard to open it back up. On the other end of it is over-distension, meaning you give too much pressure and you end up distending areas of the lung. And it's, the areas that you're actually going to distend more are probably those areas that are healthier and less affected by ARDS because they can accommodate and accept those pressures, but they get then over distended. And what can happen is you can actually injure the lung more if you give too much PEEP, or even get a pneumothorax if it's really high, and continue, and you injure the lung. And so what we try to do is find that happy medium in between those extremes of recruitment, under recruitment on one side, and over distension on the other. And the PEEP tables, the low PEEP table is one that I find helpful and I kind of use in my mind as I'm titrating the PEEP. And it's, if you lose the low PEEP table, you probably won't go too high, but it'll assure that you aren't going too low either. But that's how I would think about it. Recruitment, you may have heard about recruitment maneuvers where you turn the PEEP up really high, like 30 for 30 seconds and just hold it and try to pop open the lung. Don't do that. That's not a good thing to do. That's been studied, and not only does it not improve hypoxia, because basically the lung just goes right back to the way it was, but patients actually had cardiac arrests during these events because the pressures are so high, and the preload drops significantly. And so recruitment maneuvers really should be something of the past and should not be done. But adequate PEEP is important. So try to think about it in those terms. You don't want too much, you don't want too little. One thing also to consider, and this is a little bit, this can be a little bit more challenging, is what to do with very obese patients, patients with very large abdomens. They often require more PEEP just to push back against the abdomen and adequately inflate those bottom parts of the lung. And so that can be more challenging, but those patients often need even more PEEP.
Thanks, David. This is from our colleagues in Bhutan. So
it's great.
Really our good almost night over there. So I'm glad they were able to join. Any other questions at Mabingo? Okay, seems we are doing good there. I will check if we have any other questions from our audience. Nothing else? Okay, wonderful. Well, we're just about at time, so thanks for being really efficient with the talk. And to all our topics are, to all our audience, all our topics are based on our collaborators and collaborating sites as they request. So if there's any other sites that are interested in being a formal classroom with us, we're happy to work with you. Otherwise, all of these lectures are available free of cost online at healthfortheworld.org/academy and also on the YouTube channel. And well, nice to see you all over there in Mabingo. If you want to come close to the camera, I can take a quick photo with Dr. Avi, and then he's very active on Twitter, so he'll make you popular on Twitter as well. Or I suppose that we're probably socially distancing, so it might be hard for all of you to come close in the camera. It may not be appropriate. So having said that, we will see you next week then.
Thank you very much. Thank you for the invitation. It was really very special. Thank you.
Thank you for taking our time. And thank you for all our international audience as well. Thank you all. All right, we will be closing now. Bye everyone over in Mabingo. Bye, Dr. Cooper.
Bye everyone. Take care.